معايا اهو فين. تعال بسم الله.
بسم الله الرحمن الرحيم. I would like first of all to thank GSK for organizing this symposium dealing with an important topic in oncology, the soft tissue sarcoma, and the recent advances in its management. And I have the honors to invite my colleague, Professor Dr. Tariq Hashim, a well-known figure in oncology, to give us his view regards this important tumor.
Mr. Chairman, thank you for the introduction. I'll start by the disease background of soft tissue sarcoma. As you all know, sarcoma are a group of rare solid tumors arising from mesenchymal tissue. Soft tissue sarcoma are the most frequently occurring sarcomas. Sarcomas consist of soft tissue in 80% and bone sarcomas in 20%. Soft tissue sarcoma accounts for less than 1% of malignant tumors. However, the incidence is often underestimated because it only includes sarcomas arising in soft tissue and not those arising in specific organ sites. The incidence of soft tissue sarcoma increases with increasing age, and the majority of the patients are above the age of 60. Soft tissue sarcoma develops most frequently in the thigh, but it can occur in almost any anatomic sites. Extremities accounts for 60%, trunk and thorax in 19%, retroperitoneum 15%, and head and neck in 9%. These are the most common types of soft tissue sarcoma and their tissue of origin. Leiomyosarcoma is the most prevalent subtype in epidemiological studies, and the relative frequency of other soft tissue sarcoma subtypes varies by study and nation. In the United States, the commonest histological subtype is leiomyosarcoma, followed by malignant fibrous histiocytoma. In Europe, sarcoma of not otherwise specified are the commonest type, followed by leiomyosarcoma. Disease-free survival in soft tissue sarcoma has increased substantially with the introduction of multidisciplinary approaches, and the 5-year overall survival in patients with soft tissue sarcoma is almost 50%. As expected, the 5-year survival in soft tissue sarcoma varies depending on tumor stage. Patients with stage 1 has a 5-year survival of 90%, and the patient with stage 3 has a 5-year survival of 56%. Also, the 5-year survival in soft tissue sarcoma varies depending on histological subtype. Patients with histological subtype of dermatofibrosarcoma and liposarcoma has the favorite 5-year survival. Kaposi sarcoma, rhabdomyosarcoma, and vascular sarcomas have the worst 5-year survival. The prognosis is usually poor for patients with locally advanced or metastatic soft tissue sarcoma. Patient with isolated recurrence has a 5-year survival of 48% in comparison to 16% for those with metastatic relapse. One of the challenges facing the management of soft tissue sarcoma is the pathology. Difficulties in the initial diagnosis may be caused by the lack of familiarity with rare sarcomas. Also, studies have shown that there is often discrepancies between the initial diagnosis and second opinion from an expert in sarcoma, with a full agreement with second opinion of about ranging between 54 and 68%. Thus, the systemic second expert opinion by a centralized pathological review improved the quality of diagnosis and could potentially improve patients' management. What about treatment of soft tissue sarcoma? As with other cancers, treatment for sarcoma depends on resectability. Other factors include size of the tumor, histologic subtype, location, stage, age, and performance status. This is the treatment modality distribution, and as we can see, the black color represents the multidisciplinary approach, that there is a trend for using multidisciplinary approach in the management of soft tissue sarcoma. For newly diagnosed localized soft tissue sarcoma, surgery alone is the main line of treatment in 23% of the patients, followed by surgery plus chemo and radiotherapy in 21% of the patients, then surgery and radiotherapy in almost 20% of the patients. For newly diagnosed locally recurrent soft tissue sarcoma, surgery, chemotherapy, and radiotherapy is the main line of treatment, followed by surgery plus chemotherapy in almost 20% of the patients, and then comes surgery and radiotherapy in almost 16% of the patients. For metastatic soft tissue sarcoma, the majority of the patients are treated by chemotherapy in about more than 50% of the patients. As expected, tumor size, tumor grade, depth of invasion, as well as stage are the prognostic factors favoring survival in patients with soft tissue sarcoma. Adjuvant chemotherapy for soft tissue sarcoma is an area of debate. These are the major randomized trials that did evaluate the role of adjuvant chemotherapy in the management of soft tissue sarcoma, and there was a definitive improvement in terms of disease-free survival in all of these trials. But unfortunately, in most of these trials, the improvement in the disease-free survival has no impact on the overall survival. However, the meta-analysis of 4 randomized trials did show improvement in terms of absolute response rate, in terms of recurrence and survival when doxorubicin was combined with ifosfamide. Also, survival rate in patients with high-grade soft tissue sarcoma, especially in synovial sarcoma and liposarcoma, and in patients with tumor size more than 8 centimeters, the adjuvant chemotherapy did improve the survival. Why has adjuvant chemotherapy failed so far? First, the mixing of different histologic subtype and molecular subtype in a small cohort of patients may have introduced too high level of heterogeneity. Second, the quality of surgery and local treatment may have improved over the years, reducing the magnitude of possible benefit of adjuvant treatment. Third, the criteria used to select patients for adjuvant treatment in randomized trials may not be the optimal predictive factors for efficacy. What about second-line or later-line treatment for patients with advanced soft tissue sarcoma? These are the major randomized trials that did evaluate the role of second-line or later-line of treatment in patients with soft tissue sarcoma. We'll discuss the PALET trial in details. Other trial, trabectedin in 2 different schedules, gemcitabine plus dacarbazine or dacarbazine only, gemcitabine plus docetaxel, or gemcitabine only, sorafenib versus placebo, and 2 different schedules of ifosfamide. Yondelis is a new therapy for soft tissue sarcoma, trabectedin. This is originally derived from marine tonicate and now manufactured by synthetic process. Trabectedin binds to minor groove and bends DNA towards the major groove. The STS-201 trial is a randomized multi-center open-label trial of 2 different dosing regimen of trabectedin. The first arm received 0.58 milligram per meter square weekly for 3 out of 4 weeks by 3 hours infusion. The second arm received 1.5 milligram per meter square once every 3 weeks by a 24-hour infusion. The primary endpoint of this trial was time to progression. Secondary endpoints were overall survival, response rate, progression-free survival, safety, and pharmacokinetics. In this trial, 270 patients were enrolled. The baseline characteristics and prior therapies were balanced between both trabectedin arms. This study included 66% leiomyosarcoma, 59% high-grade tumors, and 67% bulky disease. All patients had previously received anthracycline and ifosfamide. The two arms were well balanced in terms of patients' characteristics. In this trial, there was a trend toward improved time to progression in favor of the 3-weekly 24-hour infusion arm, 3.7 months versus 2.3 months for the weekly arms, and the difference was significant. Trabectedin schedule was an independent statistically significant factor with a 32% reduction in the risk of progression with the 3 weeks 24-hour schedule. There was a trend toward improved progression-free survival in favor of the 3 weeks arm when compared to the weekly arm, 3.3 months versus 2.3 months. However, this difference was not significant. Response rate was higher in the 3 weeks arm, 5.6% versus 1.6% for the weekly arm. In terms of survival, the median overall survival for the 3 weeks arm was 13.9 months in comparison to 11.8 months for the weekly arm. However, this difference was not significant. So, significantly longer time to progression with the 3 weeks 24-hour regimen in the protocol-specified primary analysis with 27% risk reduction and 61% increase in the median time to progression. And the median overall survival with the 3 weeks 24-hour regimen was 13.9 months, and 16.2% of the patients were alive at 1 year. Pazopanib is another drug that has been newly used for the treatment of soft tissue sarcoma. The rationale of using pazopanib was based on some facts. First, angiogenesis is one of the hallmarks of cancer progression. VEGFR and PDGFR signaling pathway have an important role in the angiogenesis, and increased VEGF expression as well as increased PDGF and PDGFR expression has been associated with higher tumor grade and decreased survival in soft tissue sarcoma. So, the strong rationale for targeting VEGFR and PDGFR pathway in soft tissue sarcoma. Pazopanib is a selective oral inhibitor of VEGFR and PDGFR as well as c-KIT. Pazopanib has a capability of inhibiting PDGFR and VEGFR simultaneously, so it's more effective in inhibiting angiogenesis. Data showed that there is a correlation between serum VEGF level and tumor grade in patients with soft tissue sarcoma. Also, there is a correlation between the expression of VEGF and survival in patients with soft tissue sarcoma. On the other hand, some trials did show a correlation between PDGF and PDGFR and survival in patients with soft tissue sarcoma. So this was the rationale of the PALET trial, a randomized double-blind phase 3 trial of pazopanib versus placebo in patients with soft tissue sarcoma whose disease has progressed during or following prior chemotherapy. 369 patients were enrolled in this trial and received either pazopanib 800 milligram or matching placebo in 2-to-1 fashion. The primary endpoint of this trial was progression-free survival, and the secondary endpoints were overall survival, overall response rate, quality of life, safety, time to response, and duration of response. Patients were assessed at week 4, 8, 12, 20, and at 8-week intervals thereafter. These are the inclusion criteria for patients who've been randomized in this trial. Patients more than 18 years, WHO performance status between 0 and 1, progressive disease during the last 6 months, up to 4 lines of prior treatment for advanced disease were allowed. Patients whose disease had progressed on or after or been intolerant to anthracycline-based regimen, measurable disease according to RECIST criteria, angiotensin inhibitor naive, adequate major organ function, no poorly controlled hypertension, bleeding deficits, or CNS involvement. The 2 arms were well balanced in terms of patients' characteristics. Leiomyosarcoma was the commonest histological subtype encountered in this study. Regarding prior therapy, about 90% of the patients did receive first-line therapy, and more than 50% of the patients received second-line therapy. Doxorubicin and ifosfamide were the main agent used prior to the trial. In the pilot trial, there was a definitive improvement in terms of response rate in favor of pazopanib arm, 4% versus 0% for the placebo. And the median time to response by independent reviewer in the pazopanib arm was 8.4 weeks, and the median duration of response was 13.9 weeks for pazopanib in the responder population. Regarding progression-free survival, there is a definitive improvement in PFS in favor of pazopanib arm, 4.6 months versus 1.6 months for the placebo arm. Factors associated with favorable prognosis were performance status, 0, 1 and 2 line, 0 or 1 line of prior therapy, low or intermediate grade soft tissue sarcoma. Multivariate analysis selected performance status 0 and low or intermediate grade soft tissue sarcoma as a predictive factors for progression-free survival. There is a trend towards improved overall survival in favor of the pazopanib arm, 12.5 months versus 10.7 months for the placebo. So in summary, pazopanib demonstrated a significant improvement in PFS with a median PFS of 20 weeks versus 7 weeks for placebo. Pazopanib delivered a 65% reduction in the risk of progression or death compared to placebo. Also, pazopanib provided a significant improvement in PFS compared to placebo across multiple soft tissue sarcoma subtypes. Finally, pazopanib demonstrated an improvement in progression-free survival versus placebo in patients with soft tissue sarcoma that was consistent regardless of the number of lines of prior therapy. Looking at the adverse events, grade 3 adverse event mainly was fatigue in 13% of the patients, hypertension in 7% of the patients, and anorexia in 6% of the patients. These are the major randomized trials that did evaluate second line or later in the management of patients with soft tissue sarcoma. And as we can see, the progression-free survival was the highest progression-free survival achieved in the pazopanib arm. So in conclusion, across the randomized controlled trials, pazopanib over placebo, gemcitabine dacarbazine over dacarbazine, and trabectedin 3 weekly over weekly regimen clearly demonstrated a PFS advantage in second line or later line treatment for advanced soft tissue sarcoma. Among these trials, the highest PFS was observed in pazopanib arm, 4.6 months. Pilot trial is the only one phase 3 trial in this setting, and there is a clear need for additional comparative trial to better understand the risk-benefit ratio of available agents and combinations. Thank you.
Thank you very much, Professor Tariq, for such an elegant presentation. I believe now the floor is open for discussion.
Dr. Ahmed.
Let me have the first question. Take the advantage. Well, I believe the group of patients treated in the Palette trial were heavily pre-treated patients.
Yes.
Yes.
Actually, more than 50% of the patients did receive more than 2 lines of treatment.
It's a quite challenging.
And again, there is 15% of the patient who previously received tripectidine at the 3rd line. So
really?
the group of patients included in this trial carry a poor prognosis. That's maybe was observed in the other arm, the lower
The
progression-free
observational
survival.
arm, definitely, yes.
And the placebo arm.
Yes, the progression-free survival was in fact spectacular, almost 3 times.
Exactly.
Yes, but this was not translated, in fact, into survival gain or benefit. And what we see is almost 2-month difference. So do you have an explanation for that?
This is related to the power of the study and the number of the patients. The power of the study didn't allow for proper evaluation of the overall survival. This is number one. Number two is the quality of the patients. Most of the patients carry a poor prognosis. That's why even in the placebo arm, the survival was relatively lower.
Right. Any questions?
Dr. Tariq, thanks a lot for your presentation. I have a query. Is there any head-to-head study comparing newer drugs like trabectedin and bazobanib in this setting, or we have now bazobanib having progression-free survival over reaching more than 4 months compared to 3.5 months in the trabectedin, but is there any head-to-head comparison for the two drugs?
Right now, there is no head-to-head comparison.
There is no,
but as I mentioned, this trial included patients who have already been treated by trabectedin at the 3rd line.
Okay. Okay. And what about the adjuvant, very important issue, the adjuvant therapy in patients with soft tissue sarcomas?
As I've mentioned,
Yeah.
adjuvant chemotherapy in soft tissue sarcoma is still an area of debate. There is
Yeah, of
some
course.
data about giving adjuvant chemotherapy in high-grade liposarcoma and synovial sarcoma, especially if the size of the disease is more than 8 centimeters.
Okay. Any question?
Any question, please?
Thank you, Dr. for this presentation. I have a comment for the question asked by my dear professor. When you do a study comparing something to placebo, you don't look for survival. You don't look for overall survival. You just look for progression-free survival.
Absolutely, I totally agree with you.
And not for progression-free survival على المطلق. You do a progression-free survival at a specified point.
Exactly.
And this point will be determined by the number of the patient in the study. You increase or decrease the time according to the number of the patients. So you're looking for a progression-free survival, not for survival.
Well, as I've mentioned, the problem in any trial in the field of soft tissue sarcoma is very difficult because of the rarity of the disease and the different histological subtypes. You have different histological subtypes that you actually don't know the difference in terms of the natural history of the disease between the different histological subtypes.
Okay. Thanks a lot, Dr. Tariq, for this high-quality presentation. And now the session is closed, and we'll move to the next session because you are far beyond schedule.
Thank you.
Thank you.